Every 20 seconds now, someone develops an amputation because every second someone around the world develops a wound, a diabetic foot ulcer. And that's usually because they wear a hole in their foot, like we'd wear a hole in a sock or a shoe. We talked about it being quiet because people don't feel pain when they're supposed to, right? And so they're not going to behave the same way that we would or they would before they lost that gift.
Dr. David Armstrong is a globally renowned foot doctor and surgeon with expertise in the diabetic foot and limb preservation. He holds 3 doctorates and has made significant contributions to over 100 books or book chapters, as well as authored more than 600 peer-reviewed research papers published in prominent medical journals. Really, I want to talk more about your work within the diabetes community. Obviously, we know you're well-established, you've published so many publications. You're almost a world-leading figure in the diabetic foot. You're around the world traveling, providing educational value to so many other countries which perhaps don't even know too much about diabetic foot care.
Well, Ramneek, that's really that's kind introduction. And I think, I guess if you were a sinister deity and you were trying to figure out a way to sock it to humanity, you wouldn't pick something loud, like a heart attack or even COVID or even HIV, AIDS, all these terrible things, these scourges of our time, even cancer, right? You'd pick something quiet like this, and so sometimes in order to do that, and in order to sort of spread the word about, first of all, the problem, and then when people look, they say, oh my God, I didn't realize, because they just look at the data in their own communities. And then the good news is that even amidst all the bad, there's a lot of good that can be done. And that's the exciting part of a lot of this. And this can happen in communities where there are really great healthcare resources. An example, I was just in Singapore now, just like maybe a few hours ago, where there are superb resources across 5.5 million people in a tremendously diverse community. And then in other communities where maybe there are not as many resources available, and even in those places where you'd think that there'd be a lot of resources, like Singapore, there's still what we would call, Ramneek, like a postcode lottery, right? A zip code lottery, where if you're in one area, one kind of hyper-local area compared to another one, there could be a many-fold difference in amputation. Example, here in Los Angeles, right? In different zip codes, there is now and this is work from our friend Stevens and coworkers from UCLA. This is 10 years ago, but the data were just repeated in other cities, including Los Angeles this last year. In adjacent zip codes, you could have a 10-fold difference in amputation from one to the other. And then, so that's kind of the big thing, right? So that's bad, right, in terms of health disparities and issues of social determinants of health. But then if you just look in the same zip code, in the same area, the same community, like one of our communities, and there might be 2 hospitals adjacent to one another, and one hospital has an amputation rate or a high amputation rate that is several-fold higher than the one that is only a block or 2 away. And you say, how is that possible, right? Is one, seeing a higher acuity of patients? Well, sometimes that's the case. But very often what it shows is that it could be one person, one doctor or nurse that has an interest in the area or not to make a difference. And so what you see is that you can make a difference on the macro end, right? Kind of looking out on a map. But then more importantly, even for all of us, is that we individually can have a difference on the micro end. And that is what is, I think so exciting. To see not only in Singapore, but right here. I was just talking to a friend of mine, David Toby, who's a vascular surgeon at Martin Luther King Hospital here in Los Angeles, and he's been making a difference there for the last 4 years. He was just trying to figure out ways to kind of harmonize things with what we were doing, maybe just a few blocks away in another hospital. And there you go. That's something that were just doing a few hours ago.
Now, I've got to highlight the big scare over here. The statistics pointing out, I don't know where the data's from, but if you go online, you can find information where they say every 30 seconds in the world there's an amputation. That's frightening. And it goes back to a lot of people don't understand what diabetes is or what the complications, which is the highest risk aspect of having a lower limb amputation. And I think there's a big disparity in information to the public because a lot of people, like I said, they don't understand what diabetes is, but everybody would have a friend or a family, I'm sure, and I don't have the data, but there's always someone who has diabetes, and the information is so valuable, yet they don't know much about it.
Absolutely, Ramnik. And I'll give you an example. I'll actually now update you. It's actually not every 30 seconds, it's every 20 seconds now. I sent you a little link. You could go, we just had a paper in JAMA that has kind of the latest and greatest data on this area, both good and bad. You're talking about some of the bad there because, it's basically every 20 seconds now someone develops an amputation because every second, or give or take, someone around the world develops a wound, a diabetic foot ulcer. And that's usually because they wear a hole in their foot, like we'd wear a hole in a sock or a shoe. We talked about it being quiet because people don't feel pain when they're supposed to, right? And so they're not going to behave the same way that we would or they would before they lost that gift. So they get a wound every second around the world. That's called a diabetic foot ulcer, or a DFU, as it's the acronym. About half of those get infected, give or take. And then of those infections, about 20%, depending on where you are admitted to hospital. And then of those, pretty significant proportion will end up in some form of amputation, which is why you have an amputation now every 20 seconds around the world. And as we talked about earlier, there are tremendous variations even inside individual communities based on resources and whether teams are put together to treat this and to look after it. And, we always say it's about team, technology, and tenacity, right? And so, but these teams, when you put them together, they can really make a big difference.
Just to let everyone know, an ulcer is a wound, but it's happening internally. There's a hole coming through your foot, and sometimes it can extend into the bone, but it becomes infected. That's a problem. If it becomes infected and if an antibiotic doesn't work, then unfortunately the last course is an amputation because we're trying to salvage that limb, because if you don't do that, it could spread and you could die from that. But the sad thing is that even if you do have an ulcer, the reoccurrence of it happening again is almost 50%. If you have an amputation, your life expectancy drops even further. I believe it's like they say 50%, but yeah. I'd like to hear more about your thoughts on that.
Yeah, you're right. Everything you've said is absolutely bang on. So you mentioned about how people develop wounds. It's really often from repetitive stress, and then you can get whereas normally you would develop, because of that stress, you get a blister and some pain, right? And if we have a blister, right, we say, blister. And so we change the way we walk or we stop walking. But imagine if you didn't feel that and you just kept walking through it with that blister, and it just gets deeper and then ultimately infected. And one of the other things that's happening at the exact same time as people are living longer and long enough to get this neuropathy, they're also developing vascular disease, just like in your heart. The very long vessels, the longest blood vessels in your body, go all the way out to the end of the foot. And so there's a lot of area there to develop vascular disease. And so you develop what's called peripheral artery disease, or PAD. And that PAD is happening at the same time. And that is like that's the life fuel to try to keep your cells alive, right? The oxygenation to try to keep it alive. And when you turn down the spigot there, that can reduce the risk for the reduced chances of that wound healing, and also increase the risk of more, if you will, gangrene. So these things are all happening in a sinister sense at the same time, and they're all conspiring kind of physiologically to create this terrible problem. And it's quiet. Again, these things don't hurt very much. And so folks often are silent about the problem until the problem, it just sort of overtakes them. And you mentioned the fact that this is life limiting. It is. And when you get a wound, already your or mortality at 5 years, people with a diabetic foot ulcer is about 30% mortality. That's if you get an amputation, as you mentioned, anywhere from 50 all the way up to 80% mortality at 5 years. So this is worse than all but the very worst cancers. You look at 5-year mortality for most breast cancers, it's about 18 to 20%, thank goodness now. Lung cancer, 70, depending on the type of lung cancer, and certainly pancreatic cancer. So these problems are bad. And we would never think of withholding therapy, right, on someone with lung cancer or breast cancer. But it happens all the time. There's like a nihilism or pessimism around this problem with diabetic foot, because the thought is, she's got this problem. She's just going to get another one. Just cut the foot off and be done with it. And, that's generally speaking, not the best treatment for these patients. And the data are really strong showing that doesn't have to be the case.
I think what's interesting is that I was talking to a few people, clinicians in the US, and they were telling me stories. They're not podiatrists, as per se, but they've told me they've known of people, perhaps in the circle of friends or family, who are diabetic. They either died from diabetes complications or they had an amputation. And I was kind of shocked to hear a lot of stories from that, because I've been working in the diabetic foot clinic in London, and I'm coming across patients with diabetes all the time, but there are only a few cases that actually led to these complications, amputations. Don't get me wrong, it's happening every week, but it's far and few between. And it goes back to what you said, it's like the postcode lottery. You could be in one area where there's a lot of cases of this happening. It could be a lot of factors, the demographic, the ethnic background of the person, because obviously people who are Asian, Black, Indian, Latinos here, they have a higher risk of predisposition to diabetes compared to Caucasians. So that data is quite plausible. So many factors going on.
Yeah, there are. I mean, all of these, not just, in terms of ethnicity, but a lot of other social determinants of health, you may have to work another job just to have food on the table, and not to be able to afford, a quality meal, and have, literally food insecurity on a day-to-day basis. It's something that many clinicians don't even think about when they're in the clinic or in the operating room, or operating theater, to translate Ramnik. But yet that is likely far more important than the surgical procedure that they're going to be doing on that patient to try to reconstruct them. And so it's all of these things at play. But again, there is bad news there, right? Like it is with a lot of other chronic diseases. But as I said, there is thankfully a lot of good news, and that there are therapies for our patients. And it starts with making sure that you're seeing, that your clinicians, your family physician, your GP, and for sure your foot doctor. If you just see the podiatrist along with one other member of the diabetes team now, there's a net protective effect for an amputation anywhere from, on the low end, if you're low risk, about 20%, and on the high end, anywhere from 2/3 to 80% risk reduction for high-level amputation if you're at high risk. So it's like the more you need it, the better it works, not the less you need it. So go see your family doc, go see your foot doctor, and when you're in there, just, as we say, knock your socks off so that they can have a look at your feet, and you'd be amazed at the kind of things they can pick up. And then on the hyper specialist side, when seeing the foot doctor, and if she or he is a member of a interdisciplinary team, typically you then have a really good pair up with your vascular surgeon or other vascular specialist, And we call that pairing up, that kind of mash up the toe and flow model, where you have a toe doctor and a flow doctor together that are looking after the foot and the wound on the foot, or trying to prevent that, and then the blood flow down into and running off into the foot. So that combo is dynamic, and that's one we've been fortunate enough to kind of work on for a number of years, for a whole generation, really. And we're just sort of copying what people did before us. In fact, back in the early days of diabetes, Elliot Joslin, who was a real giant in the area in Boston, when he had just learned about insulin being available, saving people's lives, he started using it in Boston. And, we're talking about now almost 100 years ago now. The first two people he hired, when he started seeing people were living longer now from this magic potion insulin, the first two people he hired were a general surgeon, now the equivalent maybe of a vascular surgeon, and a foot doctor. Back then they called it a chiropodist. And those were the first two people that he brought into what is now the Joslin Diabetes Center, right, in Boston. And so even back then, the first thing they saw was that this is a team sport, and, no clinician is, if you will, unto herself or himself an island. And so bringing that together can really make a difference. And now we're seeing this around the world. If you put a team together, the data show, just by putting the team together in almost any way that you put the team together, there is no kidding, on average, a 60% reduction in risk for amputation after putting that team together than before putting the team together. So there you go. And then you can do even better as you kind of, spice it up with other, improvements, as it were. So it's, like I said, it's a really exciting time, even though, there's a lot of bad stuff going on. There's also a lot of really, really good stuff going on. So for me, it's an exciting time to be a toe doctor.
Interesting. I've got two questions from that, but the first one to go back, because you mentioned something quite interesting about the work of insulin. Now, I was actually doing a bit of research on metformin because it's come in the headlines as this new anti-aging drug.
Yeah.
Really, it's a drug used to treat type 2 diabetes. And what's interesting is it was available first in France in 1952. It was available in the UK in 1953, but it came in the market in the US in 1995.
Yeah. I remember as I was coming into San Antonio at that time, I'm in Los Angeles now, but when I was just a young fellow training in what then became what we called the Texas Diabetes Institute, my colleagues there at the TDI were they had been using metformin, for some time experimentally, but the drug was already really long in the tooth. But this is a product that has a long history of safety and efficacy. And it's one of those things, kind of like statins, where there's a lot of upside and not a lot of downside. And now, of course, many women and men that have been doing a lot of work in aging are finding the kind of so-called mTOR effects of metformin and others. So, like I said, between that, statins and other what we call best medical therapy, there is a lot of promise. However, for our patients that are at high risk for getting amputations, very few people are on what we would call best medical therapy, where they're getting that best medical therapy. In some cases, it's just a quarter of them. In others, it's a little more. But there's a lot of good work that can be done. And by the way, Ramnik, that's true in studies in the UK as well as in the US. So this problem exists, I won't say universally, but nearly universally, where there's a lot of good effort that we can do. And so we can look worldwide at opportunities for improvement.
Would you ever use metformin for anti-aging yourself?
Sure, yeah, and I think the data are really compelling, and I think there have been some clinical trials that have. I'm not sure if they're still ongoing, but I think those things can show some can definitely show some promise. So I think people could probably use this sort of thing for that purpose as well, sort of, if you will, off-label, and maybe that ultimately becomes on-label, especially now that other people are looking at other types of so-called anti-diabetes or diabetes drugs that are drugs that have effects on different from.
It's not currently approved by the FDA to be used for anti-aging.
No,
but there's actually a trial being done. I can't remember this. He's quite popular. He's on YouTube. He's a doctor and he specializes. He's doing a trial on this. So it's like he's trying to do a trial so then it can be approved by the FDA because they found data where they compared people who are using it, who were diabetic, and people who weren't diabetic. Or I think what it was basically they found people who had diabetes who were on metformin had better outcomes in quality of life and living longer than people who weren't taking it. And again, I don't know too much about the plausibility of this.
Well, you know what you could do, Rebnik, maybe next time you could have, one of my friends and colleagues that are participating in that, or, I'll tell you, my longtime friend, David Sinclair from Boston, I'm sure would be happy to participate. He's doing quite a lot of work. I know he has a podcast as well on this subject. You could talk to him about a whole kind of suite of data to support some of these things. If we're getting off into the whole thing about delaying decay, if you will, as I call it, and improving kind of health span as well as lifespan, that's a really exciting thing as well. And it strangely, I'm a toe doctor, right? But it fits perfectly into the kinds of things we do because, my interests are to help folks move through the world better every day. And however we can do that, right? So people live independently, hopefully, right up until they die, and spend, I guess, as little time in the hospital, as much time in the home, and of course in the community as possible. That's the way forward. If we were to talk about kind of, for me, as again a foot doctor, we say a holy trinity of benefits would be to have people ulcer-free, hospital-free, and activity-rich. Those are the kind of benefits we'd like to see: ulcer-free days, hospital-free days, activity-rich days, which ultimately leads to happiness and, I think, dignity-filled days.
I think one thing I didn't mention is a lot of people do not know what a podiatrist is. Obviously, a podiatrist is a clinician, a physician, and a surgeon that specializes within the lower limb, pretty much below the knee.
Yeah.
I think a lot of people are confused when you say a podiatrist, they say pediatrician. But I think in the last few years, people are beginning to know more about podiatry. Because I can see that when I'm talking to people who go, yes, I know what a podiatrist is. And I think because they have access to that.
Well, yeah, thanks, Remnick. I mean, so I grew up with this. I'm a second generation a foot doctor. My dad was the smartest guy ever.
Yes.
And our oldest daughter, Alexandria, who's at University of Texas, a health science center in San Antonio now, where I actually was a young fellow and a young assistant professor. She's actually getting trained by my old fellow, is her chief now. So like she begat him who begat her. It's really, I say this a fair bit, but in working on the foot, I can think of two kind of great gifts. But the first one is kind of in this era of hubris and of, over kind of hyper overconfidence and such. I can't think of anything that is more of an expression of humility than coming down and working on someone's feet. Immediately, it's an expression of humility. And that is true across borders, across religions, across specialties. And frankly, it's even time. It's just you put yourself in a position of humility. So you start there. But then the other thing is, I mentioned my father. He used to tell me that the best gift you can give anyone, besides your love, is perspective. And when we are working on that foot, in that, putting ourselves in that position of humility, we get this gift of perspective by looking back on the leg and in the rest of the body. And it also forces us, in the best sense, to collaborate, right, with other clinicians. And so, because you're working out there on a peninsula anatomically, and so those two things I think are great gifts. And the specialty, podiatry, is a just uniquely great one. I think because of that, and because you get to do a lot of different things. It's a strange kind of paradox, because you're out at the end of this body just looking at a foot, but you get a chance to really make a difference each and every day. And it's something that you wouldn't normally think about. I know I wouldn't if I wasn't doing it, but I love it. I think all evidence would support it, and you can make a difference, right? And which is great.
Yeah, it's not the most glamorous profession, but it's one of the most rewarding ones.
Yeah, absolutely. And whatever. I'm not sure what is glamorous, right? I think it's almost like subversively. I think it's a little subversive, to be looking out there and working on these folks and forcing that collaboration. But you're right. It's wonderful to be able to do it. And I have spectacular relationships with women and men across our academy, at our university, and in every specialty. And it is so there is even with humility, there's a lot of excitement and the ability to really affect positive change. And we're working on everything from spread on and spray on skin to wearable robots to implantable sensors. So it's pretty cool.
Certainly is. What can someone do about neuropathy? We get a lot of people asking about, and they're finding it difficult managing their neuropathic symptoms. First of all, is it curable? Is it reversible? Is there anything new coming out? What have you come across, and what's the best way you might treat it, or the advice you give your patients?
Thanks, Ramnik. I'm happy to discuss it. So the data right now for neuropathy, so especially the painless neuropathy, suggests that still the best treatments right now are, in terms of the natural history of the problem, is to keep people in good glucose control, and good lipid and blood pressure control. Both of those have net protective effects in likely reducing the onset or the onset of what we call loss of protective cessation and the severity of the problem. So those two things, they sound really simple, but they're really important. There may also be some improvements in diet and nutritional supplementation that may have an effect on the natural history of neuropathy as well. Some aspects of B vitamin supplementation, protecting the kidneys as well. That's very important. With that supplementation, you don't want to overload, but there are data to support that. So that's on the kind of painless side of thing. On the painful side, I'm happy to say now that there are emerging data, not just with drugs that we've been using over the span of many years, which do have some benefit, but also side effects, but also certain topical agents that may help to reduce pain in the near term and then over the long term. But also now, believe it or not, electrical stimulation. We're seeing that spinal stimulation when with implantable spinal stem, there are some elegant data now suggesting that one can reduce very severe painful neuropathy utilizing that as well. So if you are suffering from this, there is definitely hope now, and you should definitely not suffer in silence. Talk to your doctor about this for sure.
I think there's a lot of stigma attached to that, because people think that I don't want to go to my general practitioner or primary care physician because they're just going to give me a medication which has side effects, and it's just the same, because it's like they don't know what to do. But you mentioned this hope. Is it true to say that find the underlying cause, shut that down? If it's caused by diabetes, then you want to obviously get your blood sugar levels to a good range so it doesn't cause any further damage, and then manage your symptoms. Have you seen any cases where in the long term, that's almost like made a tremendous amount of improvement in that patient?
Well, the data on the spinal stem is now over, I think, 6 to 18 months in some of these sorts of things. So that has been, so I think it's early days yet, but the data are promising in that you're seeing long-lasting relief in that period of time. And of course, when you're talking about treating patients with, getting them into a good blood glucose, blood sugar control, and good lipid control, that's a long-term kind of work between the patient and her or his doctor and nurse. And so that's important as well. So these sorts of things are the kind of things that take place over a lifetime, right? And so that's really the idea here, is that this is a sort of contract between you and your doctor and nurse. And I think now that it's a more, there's more hope now in looking after these patients than ever before.
And what topical agents do you recommend your patients, or you've come across that you feel that can offer? Value?
There is capsaicin has been around for a really long time, for more than a generation. There are newer formulations of that, folks have used other topicals as well, but I think there are data to support that for sure.
What about CBD blends?
That's really interesting. Yeah, Ramnik. So that's a great question. I'll say I'm kind of angry at myself because I don't have as much clinical experience as I should with this. I have patients that come in that will speak to the dramatic relief by the use of CBD in terms of cannabinoids, and there are some data and there are some clinicians. I've a good close friend in Canada that has a lot of experience with this as well, but there are others that are having more and more experience in this. And I look forward to more and more clinical trials to support or refute this. But you're right. I think that there may be some benefit there. And if you're getting the benefit, listen, just talk to your doctor about it. And then if you, between the two of you, go for it.
What about red light therapy? Some people have talked about they found it quite beneficial in the patients, in fact.
Well, look, I think that there are data and they're kind of mixed on light therapy. Some are completely negative. Others have some positive, have shown some positive benefit. But the larger sense of things is that there may be some data to show that just in general, kind of an energy-based therapy. And when I say energy-based, I'm not talking about something that is like you're waving quartz crystals on the patient. I'm talking about actually, there are therapies that could actually deliver, through the air, through a shock wave or other kinds of things that can deliver. They can actually deliver kind of energy transfer. That has some promise in improving and mitigating inflammation. and in maybe even improving healing in general. So there may be some promise there, yes. But I think that there have to be larger scale randomized trials to support or refute that as well.
And it depends, like not all red light therapy devices are the same if you're buying them as consumer products online. Whereas I've got colleagues who have clinics in Texas and they have their own device. That's a medical grade. It's a higher technology and they use it for patients to heal wounds, etc. That's of a higher quality.
Again, I think that the data I'm aware of on light-based therapy has been mixed, but that just because it's mixed doesn't mean that there is not a benefit. But I think the key is, caveat emptor. You got to make sure that you have a good relationship with your clinicians and that you're talking to everyone on the team about that you're getting these therapies so that everyone knows, so that you can have a good balanced look at the benefits and the risks involved with these kinds of therapies.
And the last part of this neuropathy talk, I came across Wharton's jelly. And I know there are a few studies which have been done on treating diabetic foot ulcers, but there's talks about how it can also perhaps be used to treat anything. We've seen success within arthritis, joints, etc., tissue injuries, but no one's really explored the use in greater detail for treating neuropathy. Do you know much about the Wharton's jelly stem cell therapy?
Yeah. So again, over many, many years, we've had a lot of experience with different kinds of sort of so-called cell-based therapies, and also with Chorion, Amnion products. There are a lot of data on the use of basically what we call them placental-based products in tissue repair and wound healing. The majority of these data are in one direction, showing positive results. In fact, we just mentioned those along with some other therapies in a JAMA paper that we just finished this last month. There is promise there in using those, especially if you're doing everything else right in preparing the patient and preparing the wound if you're treating a wound. So it would stand to reason that there may be some benefit from other products like that. I think they just have to stand the test of time. They have to stand the test of clinical trials in this area, and that's part of the challenge.
Definitely. I had a question about, because you talked about blisters earlier on. If someone has a blister, perhaps it's from a burn wound, obviously that's different from a blister caused by friction in the footwear. If someone gets a massive blister and it becomes filled with fluid, what's the best way to manage that?
Well, I would just say, first of all, if you're really worried about it, if you have diabetes, listen, for sure, don't do any kitchen surgery, or bathroom surgery if you can.
Bathroom surgery, yeah.
Yeah, go either whatever room, call your doc, get in to see your foot doctor for sure. That is super important.
But let's be real here. A lot of people's argument is that I don't have access to healthcare.
Yeah.
I don't know. I can't afford this.
So let's talk about that. So there may be ways. So first of all, what I'd say nowadays is, take a picture of it. And we have a whole thing we call a foot selfie program at our place. And we're scaling that whole thing up. So get a picture of it if you can. And, everyone's has access to this now, thank God. And so that's only increasing. So you can follow this and you can maybe get this over to your nurse or the doctor. The second thing is, if you are, if the blister is intact, if you have, I think maybe you can leave it intact. Again, I would try to contact your doctor, and she or he may want to lance it and evacuate the contents and then put a dressing on it. If they can't do that, you can potentially consider that yourself if it's long standing. But again, I would follow it on the day-to-day take daily pictures, if you're changing the dressing. And if you can't do it on the day, if you're on holiday, or if you are, it's in the middle of the night and you don't want to go in the emergency department, contact your doctor as soon as you can. And now the good news is you can take these pictures, and of course you can have a chat like we're having, right? Nowadays, not a day goes by where I don't have a FaceTime or a WhatsApp or a telehealth consult with a patient from somewhere around the world. That's really unusual for me to have a day that goes by without that, and I think that's true of many of my colleagues in medicine and surgery. So I think reach out. Please do not let a day go by. That's an opportunity for you to communicate.
There's actually a debate on deroofing a blister or keeping the skin intact. What's your belief or your?
I think it really does depend on the patient. Obviously, if you have a giant blister, I just yesterday had a patient with a giant blister that almost incorporated the whole bottom of his foot. It was a long story here, but I ended up initially just evacuating it and then taking the whole thing off and just putting a good quality dressing on there. We ended up putting a biologic dressing on this, while my colleagues in vascular, my flow amigos, if you will, were looking at improving the flow, the runoff into his foot. But the other, so if I have control over that, I would rather do it that way. But if you don't have control over it, then you could just, lance it and allow the dressing, or allow the skin itself to serve as a biologic dressing. The problem with that is that if you don't keep the area clean, you can introduce bacteria into that area, and it may. And again, there are no data, to my knowledge, on this, but that may increase the risk for an infection. The key, though, is measuring what you manage, right? Following up on this thing, communicating with the nurse and the doctor they're looking after you, and that's more important than whether you de-roof something or you don't de-roof it. I think the key here is care, and the answer to that question is it depends on where you are and when you are and what access you have to different tools and technologies. But communicate.
I agree with you. I'm also the same too. I used to de-roof them because I could manage. I was going to see them next day and follow up. So I had complete control over that. However, in my last place of work, I was working with clinicians who were kind of against that. They were kind of old school. So they saw me doing that and they kind of had a word with me. They go, you shouldn't have de-roofed that because now it's going to delay the healing. But then I looked more into the data, and it was just like in two schools of thought. Yeah. The data wasn't strong for one point.
Right. I think it really depends. If whoever had a word with you, maybe needs to crack a book, or maybe to look at different things, or maybe, understand that, the key is, you want to have a quality wound healing bed there. Now, there are some kinds of wounds that you do want to dry out. But many of these wounds, especially if it's a full thickness wound, the data suggests that you want to try to have good moisture balance. You don't want to just dry the thing out and let it wither, because that will not heal. There are some times when you need to do that. In the case, let's say, of the gangrene, where you have dry gangrene, you want to try to keep it that way, and you want to keep it uninfected that way. But in terms of other kinds of problems, in terms of what we would call wet gangrene or other problems like that, you definitely don't want to do that, and you want to eliminate all of that non-viable tissue and kind of move forward toward healing. So it really does depend.
Also, you can't really see what the wound looks like because the skin's on top.
Yeah.
You need to get to see what it looks like as well.
There are plenty of times when we will have someone, this is a daily basis for us, and I'm sure it would be with you if you're seeing patients, where they may have a blister, and underlying the blister is a wound that goes all the way down to tendon or to bone, and they didn't feel that. That's a necessity to debride. Otherwise, that just puts the patient at really significant risk. The other thing is, even let's move from blisters to calluses. So calluses are more important because a callus tells you where there's a problem, right? Now, if it's you or me, then a callus is going to hurt us, right? If we're walking and we're going to change the way we walk, or maybe even, shave that thing down ourselves. But for our patients with diabetes who don't have the gift of pain, as Paul Brand, one of my mentors, used to say, then that just serves as a nidus, a focus of pressure, and that will create a pressure underneath, which will kill the skin. You can have a blister involved in that too, and then that can ultimately, lead to tissue loss underneath. So it's really important that the doctor, the podiatrist, trim down that callus at a regular visit. And there are plenty of times where that doctor will do that, and there'll be a wound underneath. That is not the podiatrist creating a wound. That is uncovering the wound that is underneath the callus. And you can see that by their patients that have bleeding into callus. We talked about cancer and the diabetic foot being like cancer. These calluses, especially the ones with bleeding into the callus with heme in them, that's like a breast lump, right? And it's a coming event, and it has to be explored. It's really important for it to be explored. If you don't explore it, then, it's at your own risk.
And yes, it's interesting you mentioned comparison to cancers, because a lot of people it's spreading. The projection of 2028 to 2036 shows a trajectory where the population around the world, specifically in America, is increasing significantly, and therefore there are going to be more people who are going to be, they've got a higher chance of being infected with an ulcer, which could lead to an amputation. And I think the media doesn't talk about it as much, which is quite shocking, because it's just, you only come across this when you have the problem. I've spoken to people who perhaps didn't even know anything about podiatry or how to look after the feet, yet they're diabetic and they're on metformin. It's just shocking, like if they could have access to someone in the podiatry field at an early age, at an early stage, that would help their treatment significantly.
Yeah, I agree with you.
So where can people find you?
Oh, well, we'll probably leave something in the show notes for them. They can probably ping me at our, on Twitter or X, as it were, or on LinkedIn, or certainly on our blog, wherever you like. But I am I'm a professor of surgery at Keck School of Medicine of USC, and you guys can find me anytime there in clinic with one of my colleagues, either my toe migos or my flow migos, at our salsa clinic. And, you're welcome to ping me anytime. This is an absolute pleasure. That's our goal. Our goal is to eliminate preventable amputation over the next generation. And we can do it by putting together the team and getting the word out. And Ramnik, I thank you so much.
Well, David Armstrong, it's a pleasure having you. Thank you so much for coming on the show. Appreciate that.
Man, the pleasure's mine, for real.